Respected MD in charge sir, my senior colleagues and present doctors. I am going to present endoscopic DCR being done in Central Hospital South Eastern Railway. Till date we have done, this is the last case we did on Tuesday this week. One lady coming from Orissa, Balasore. She was having swelling in the medial cathal region, both eye, and referred to me from our ophthalmology department with history of watering and swelling. And this is the post-operative picture. दिख रहा है ना साइड से?
वेरी गुड बहुत बढ़िया. इतना इम्प्रूवमेंट हुआ है
सर. इमीडिएट पोस्ट ऑफ सेकंड डे, थर्ड डे.
अच्छा.
थर्ड डे पिक्चर दिस इज.
अच्छा.
So this lady Annapurna Das is very interesting history. She is a designation. Her designation is Khalasi, but doing the work of mason. She is having worked with cement and this balu. So possible etiology maybe this cement is getting inside the lacrimal sac and creating some scarring leading to block. And total of 7 cases we have done so far in last 3 years, because I am heavily dependent on Department of Ophthalmology for cases. Nobody is coming to me directly. And the first case I did was failure, because that time I was not having proper exposure and proper instruments. After that I started gathering instruments and I went to Trichy. There I learned it how to do it properly. So thanks to Department of Ophthalmology for sending me the cases. Regarding anatomy of this lacrimal system, this is the lacrimal gland situated in the lateral upper part of the eye. Here tear is being formed, secreted, and the excess of tear is entering to this canaliculi, coming to the sac which is situated in nose, and the opening is just below inferior turbinate. So the excess tear is coming through this route and coming into the nose, and that's why preventing the watering from eye. If there is a block in these two canaliculi or this duct or anywhere in the system, so the excess water will start coming from eye itself. This is how the tear film forms. This is one lipid layer, then aqueous layer, mucin layer, and this is cornea or conjunctiva. Conjunctiva will have some cilia. This is gross anatomy. This is septum. This is middle turbinate. So we have to do surgery in this region. This is uncinate process. Here we create one area. We remove the mucosal flap. We make a mucosal flap and expose the bone. Remove the bone. Expose the lacrimal sac and create a window in the sac and make the bypass this block. Block is somewhere this place. So we are creating window here. So tear will come directly into the nose, nasal cavity. So excessive watering from eye is known as epiphora. There are many reasons. Excessive tearing is it may be hypersecretion due to irritation, any infection, allergy or trauma to the ear, or maybe due to reduced outflow, that is due to lid malposition or duct obstruction. So endoscopic DCR mainly we are discussing dealing with this duct obstruction part. All other things are being managed by ophthalmology department. And it is more common with advancing age. Women are more prevalent, 9 to 10% prevalence at the age of 40 years of age, and 30 to 40% prevalence at 90 years of age. This lady again, 53 years female, referred from ophthalmologist with diagnosis of nasolacrimal duct obstruction. What happens? Usually they do this syringing test before sending to me, and they confirm that this is block of nasolacrimal duct. Then only I proceed. Otherwise, I will have to do either syringing test or some dye test. So, what are the etiology of epiphora? There are many reasons, but I am dealing only with this thing: partial or complete stenosis of nasolacrimal duct. So I am dealing with the obstruction. I am doing endoscopic DCR. First, we have to determine the level, at which level the block is there. If it is at the canalicular level, nothing to be done. Patient has to live with like that. Then irrigate the duct to see the block level, that is syringing. Then we can do some imaging studies, but these are very expensive, so we can rely on syringing test at our setup. One CT scan taken from net. This is nasolacrimal duct, maxillary sinus. This is blocked. This gray area is blocked. It should be black. So, how DCR has been evolved? Dacrocystorhinostomy. Function of DCR has not changed. Divert the lacrimal drainage into the nose through an osteotomy in the lacrimal bone. It may be done externally or endoscopically through nasal route. External approach is still most commonly done by ophthalmologists, but nowadays there is a tendency that they are referring this patient to, especially in government setup, to ENT department, because it takes a lot of time. One surgery they will do external DCR. By that time they can do 6 or 7 this external cataract surgery. Good morning, sir. So, originally described in 1904 by Totti, resecting the lacrimal bone and lacrimal sac and nasal mucosa. By 1920s, these gentlemen, Dubois and Dutemps, described using flaps of nasal and lacrimal mucosa to create an epithelial lined fistula to prevent restenosis. This still remains the gold standard for acquired nasolacrimal duct obstruction. And the latest popularization is in 1970s and 80s by endoscopic route, and since then the technique of creating proper flap has developed, so nowadays failure are very rare. Now lasers has been available, so with laser we can create accurate window in the lacrimal sac and to prevent restenosis. Then mitomycin C may be used to prevent stenosis. Then we have got powered procedures. In our hospital also it's available. So with that drill, we can drill out all the bones. Because with the chisel, hammer or this bone punch, sometimes it's not possible to remove adequate amount of bone. These power instruments are very helpful. And different mucosal flap techniques. This is pictures taken from our hospital. This is part of septum, visualize here. This structure is middle turbinate. Initially we put a platelet of adrenaline, pure adrenaline, to decongest the area. That's why it's looking very white. We have already injected this local anesthesia in this region. this is uncinate bone, this area. So we have to create some mucosal flap here. There are many techniques. Initial technique was creating two horizontal lines here and here, then one vertical line joining these two lines and making a flap which is posteriorly based. Now technique has changed. Now we are creating superior line here. This is superior line. This is the right side. This is left side. This is right side. This is superior incision, anterior incision. Then one incision is given posterior here. This incision posterior, and a small piece of mucosa is being removed. This piece is to create a window and prevent restenosis. And inferiorly it is attached. So this is inferior based flap. Some people make different type of flap. Some people make one superior, one inferior, and middle, and one anterior. So this mucosa will go partly up, and this will go partly down. So there will be a window here. There are different types of techniques. Then after removing the bone, we are using the micro drill inside nose to remove adequate amount of bone. This bone should be removed properly. This is the middle turbinate, just anterior and slightly superior to that area. Here we can find the lacrimal sac. So we are removing the bone. After removing the bone, we can see this is photo of right side. Sorry, left side. This is middle turbinate. This is part of uncinate. This area is part of uncinate, and this area is already open lacrimal sac. This glistening area is the posterior, and this area is lateral wall of lacrimal sac, already opened. This is edge of that open part, and this is another edge. Then after repositioning the flap, we put some Neosporin ointment or T-Vac ointment over the window, that exposed area. This is another side, right side. We have already placed this ointment. This is middle turbinate. This area is here. Some part is open still. बाद में डाला था ointment. ये lacrimal sac opening. This is one photo taken from net, not from my patient, because follow-up में फोटो खींचने का सिस्टम उतना अच्छा मेरे पास आया नहीं. अभी खींचना शुरू किया. कुछ पेशेंट का किया पहले का ठीक है. एक पेशेंट फेल्योर हुआ था पहला केस. So after the surgery, it will look like this. This is patient we did on Tuesday this week, and 2 days post-operative. Completely resolved. Sir, it's not very visible, but I'll tell you. The post-operative period, we have to take care of the restenosis. For that, what we do? We give antibiotic steroid ear drop from 2 days prior to surgery we start, and we will continue till 2 weeks, 3 weeks like that. Then in nose, second post-operative day we give normal saline nasal spray, then decongestant nasal spray, and steroid nasal spray for 2 weeks. Then usual antibiotic, anti-inflammatory agents as per requirement. And we have asked the patient to come after 2 weeks. Then we'll do endoscopy again, and there may be some crusting and all those things we have to remove. Thank you, sir.